All right, thank you very much. I also tend to talk softly, so if you can't hear me, let me know. I tried to turn the mic up as loud as it'll go. Um, it is a pleasure to be here, and Dr. Nelson has been a friend for many years and has helped me on MRI analysis in our studies, so I'm very grateful for that. And I was asked to talk about stem cell transplant for MS, and there's a lot of misleading things out there, and I think one of the first things to realize is, don't panic. Okay, when you talk about stem cell transplant. And for autoimmune diseases, there are now two diseases where randomized trials have been completed. And I'm not going to talk about systemic sclerosis, the first one here, except, got a head there in the way, except to say that, do you want to move? Yeah, thank you. Except to say that there have been 3 randomized trials completed. The first in Lancet in 2011, and we stopped it early because it was so strongly in favor of transplant compared to conventional rheumatological therapy. And then we had the final follow-up from that study, 2013 in Lancet. And of course, the transplant was markedly superior. And that was done by my group. And then in 2014, the Europeans reported their results, and transplant was superior. Our study was called ASSIST. Their study was called Aztec. And then and that was by Van Laar and Farge in Paris, France, and Van Laar in the Netherlands. And then finally, New England Journal 2018 by Sullivan et al. Reported their results, and transplant was superior to conventional therapy. So with 3 randomized trials, there's never going to be another randomized trial. However, a couple things we learned from that, even though it's superior, and superior in terms of even just mortality alone from the disease, that it improves mortality, we do need to make the procedure safer. And so I subsequently wrote an article in Nature Rheumatology saying, highly efficacious, but we need to make it safer, and we're doing that. And there's just no time here to talk about that. I do, however, want to say one thing. The most intense regimen, which was myeloablative, was from the United States, New England Journal of Medicine, 2018. These other 2 regimens, the one I used and the one the Europeans used in JAMA and Lancet, were non-myeloablative. And if you look at those studies carefully and compare all the results, it appears that the least efficacious, although it was better than standard therapy, was the more intense myeloablative regimen that used total body irradiation from America here. Seattle and Duke as the leaders on it. And in fact, their lung function did not improve at all. The p-value was 0.5, where if you look at the study out of Europe and my study here in America with no radiation, the lung function improved, significantly improved, and the improvement was, the p-values were the same in both studies, about 0.004. And what you see in our studies, we had no cancers in out of 90 patients. In the study in Europe, there was 1 breast cancer out of 78, but that probably wasn't related to treatment because it's a very common cancer. Whereas in the New England Journal, they had 3, and they're radiation related. They're all 2 MDS, myelodysplastic syndrome, and 1 medullary carcinoma. And the other thing is that this was the most expensive that insurance had to pay, despite NIH funding. Insurance has to pay, or the patient has to pay, and that's $250,000 approximately, whereas the treatment in Chicago was half that at $125,000. So what I want you to take home, although it was effective, and by the time this was published, they were no longer using that regimen, kind of not mentioned in there, but more isn't necessarily better. And I think it's very clear the non-myeloablative approach was superior in this disease. And I want to bring that up because that same thing is happening in MS, and we'll go into that a little bit. But in multiple sclerosis, if you look, there's my last check, 9,751 articles in a library search on transplant for MS. There were about over 6,000 for scleroderma. So there's a lot of activity going on, a lot of things being written, and there's multiple non-randomized open-label trials that support the efficacy of this treatment, and there's 1 now randomized trial completed that we did, and that was reported in JAMA in January. So again, this is a Tesla in orbit, shot into space, actually a picture from it while it's cruising to the Mars asteroid belt, and he puts right there, "Don't panic," from Hitchhiker's Guide to the Galaxy. So there is sense to what we're doing, and it actually in randomized trials is superior to standard treatment out there in now 2 diseases, but it does need to be made safer. Okay, so what about multiple sclerosis? And I thought this, our patients give us, or patients with the disease have very good descriptions for it, and I thought this by Ann Romney, the wife of a former presidential candidate from Utah. She said, it robs you of who you are. And I think that's a very good description for it. Mortality does increase after 20 years of disease because you start getting into the progressive phase and mortality increases. And of course, you're all aware of what it looks like on MRI. But before I get into our data, which is the most important thing, I want to address a few misconceptions because they keep popping up out there, and they just seem to be occurring more frequently all the time. And one of the wrong statements that's assumed is that the stem cell, the hematopoietic stem cell, is a drug, and it is not. And that may come from some people who work with the neurostem cell and they want to make it into a neuron, and it actually is a drug. But the hematopoietic stem cell doesn't have a neuroreparative effect. It doesn't repair neurons or myelin. All it is a supportive blood product. So we give a non-myeloablative regimen, and we reinfuse unselected peripheral blood stem cells. Because it's unselected, it looks like a bag of blood. It mostly is just blood with stem cells in there that were collected from the blood and nothing done to them except cryopreserved, sawed, and reinfused. And you do that to shorten the period of pancytopenia after the conditioning regimen. And even if we don't give it, they'll engraft around day 13 or 14. If we give it, they engraft around day 9 or 10. So it just shortens risk, and it makes it cheaper, and they get out of the hospital faster. It's much like a surgeon who does a cholecystectomy, but collects red blood cells from the patient because they're the patient's own, they're not allogeneic, and then in the recovery room gives them back so they recover faster and they can leave. Again, if someone wants to move away from the screen up there, thank you so much. So, you know, that's a big misunderstanding in this field. This is just a supportive transfusion blood product. The cells themselves have no effect. There's this misguided assumption of transdifferentiation that they can be transformed into a neuron or something. And it's true, under artificial laboratory conditions, you can reprogram cells, but that's not what happens here. It's been discredited in the clinical setting, that statement of transdifferentiation. Here's another wrong statement. All transplants are the same, and people that don't specialize in this think that way. And when they hear transplant, they think of these very toxic cancer transplant regimens. In fact, they're not the same because the toxicity and the efficacy really depends on the regimen. Again, please move away from the projector, thanks. We may want to move the food away. I think that's what's attracting people in front of the projector there. But in any event, the toxicity and efficacy comes from the regimen, the conditioning regimen you give to knock down your immune system, which is usually infused over about 5 days, depending on the regimen. It may be 4, maybe 6, but about 5 days. And that's where toxicity and efficacy comes. And obviously you know that. I mean, you intuitively know the toxicity and efficacy of Lemtrada is different than cladribine, which is different than Copaxone. So don't, when you hear transplant, think it's all the same toxicity. It's not. It's the drugs you use, plus or minus whether you're selecting, we don't select. That may have an effect on both those variables depending upon the disease. I don't have time to go in that. As well as patient selection. You don't want other comorbid diseases. And standard of care guidelines that you use in your treatment of these patients going through the procedure. And that really just requires experience in treating them. Here's another wrong thing I see out there. I hear people say, well, doctors just decided to do this and off they did it and that it's whimsical. And that's absolutely not true, at least not for me. It's been a 30-year endeavor, and it began with animal models, preclinical animal models, mostly in EAE and TMEV, which are animal models for MS, and I don't have time to go into them. TMEV is a viral-mediated one. EAE is purely autoimmune, and you can adoptively transfer it by transferring the lymphocytes. But from those animal models, which we were doing for about 10 years before starting clinical trials, we went to phase 1, 2, and then a randomized clinical trial. Along the way, got NIH grants. I was PI in a $10 million NIH contract. Even got grants from the National Multiple Sclerosis Society, you know, for the animal models. And we've done immune analysis to look at immune regeneration, and we've done it in collaboration with colleagues, including colleagues of mine back at the NIH. So it was truly blinded. We did the lymphopoiesis, sent it back to them. They did the analysis, and that was actually reported in Journal of Clinical Investigation, and there truly was an immune reset, and that someone wrote an editorial to it saying, out with the old, in with the new, and a marked surge of Tregs afterwards, which are regulatory cells to help maintain tolerance that just pour out of the thymus after this procedure. So it's different than the standard approach of chronic immune suppression. It's a one-time short treatment to try to reinduce tolerance. That's the rationale behind it. So there's another wrong assumption out there that there's some sort of financial motivation to do this, and that is so horribly, horribly wrong. It's exactly the opposite. We're on fixed university salaries. You know, we're not running a clinic in the Caribbean. We don't do the billing. The university hospital does. There's no companies involved. There's no patent. There's no license. There's no royalties at the end of the day. So unlike a drug company where they get a license and royalties and will make a profit, we don't. We'll do all this work in the hope that we eventually teach other people to focus on this and do it so patients won't have to come so far to be treated at our own center. But we'll get no financial benefit from it, and that's not why we're doing it. We're doing it to try to fundamentally change disease. And here's another question that comes up all the time, again, from people who don't understand the field. They say there's something unethical about patients or insurance paying for this. Well, that may be true, but that's not the reality of the system we live in. In the system we live in, insurance has always had to pay for all transplants, whether it's cancer or autoimmune disease. And when I got the first NIH contract to develop this field for $10 million, it said in the contract, in writing, this $10 million, nothing will be used to pay for insurance. You must have insurance pay for it or the patient does. And that's how every NIH contract that has supported transplant for autoimmune disease has been written and done. Insurance has to pay. It's just the way it happens. So the other, and probably one of the reasons why insurance has to pay is because there is no drug. There is no license. There's no profit at the end of the day. Unlike a drug company, which will give the drug free and then, you know, in the hope that they can write the costs off by the high charges that and profit they'll make later. There is none of that, okay? So here's another wrong, that the stem cells have a neuroregenerative effect, and they do not. They're simply a transfusion blood product. And how it works, the real mechanism by how this works, and I say this many times, but people are confused by the name stem cell transplant. It's not really a stem cell transplant, but everybody uses that name, so we have to do that. There's no transplant. They're autologous cells, and we're non-myeloablative. You would recover even if we don't give them to you. But what happens in the recovery process, new lymphocytes are being generated and going through thymic and extrathymic tissue, and they're seeing antigen without co-stimulation, because the conditioning regimen stopped the co-stimulation. It got rid of a majority of the effector cells. It stopped co-stimulation. It stopped inflammation. Inflammation in the patient is a correlate of co-stimulation in the lab. How the immune system responds to an antigen, not only does it have to recognize it, it's the co-stimulatory molecules it gets. A lot of people want to block just one pathway like B7 and hope it works. But the problem with that approach is it's a redundant system. Cells are very redundant. There's many signals they're getting at the same time to determine friend from foe. So what we do is just knock the immune system down, stop the release of inflammatory cytokines from the lymphocytes, allow a rapid regeneration of the immune system in a non-inflammatory environment. They're seeing self-epitopes, non-inflammatory environment, and they default to tolerance. That's the concept, and we have both clinical and basic data to show that on immune reconstitution. So that's what we're really doing. It's an experimental treatment is the other thing I hear. And actually, that's not really true either, and it never was. And the reason is that you are licensed as a physician, and hospitals are licensed too, and they always must do this, give multiple drugs to a patient when they come in ill. If you're in the unit, you have many pressors going. You have a patient come in with a relapse in MS. Maybe they're on Gilenya or Copaxone, and you give them steroids. You're giving other drugs. What you're giving are drugs that were never licensed to be given together. The drugs were individually approved, or FDA licensed or approved. Some weren't, like steroids. But you, as a physician, are trained to mix them in the best interests of the patient. And my goodness, if you didn't do that, we wouldn't have hospitals, and we have patients dropping dead everywhere. You couldn't even do it with your blood pressure pills, because they look at one blood pressure pill, but often you're on 2 or 3 of them. And that approach was never FDA approved, but that's what you have to do. That's what you're expected to know. That is the art of medicine. And if you don't do it, you're not a doctor. So all we're doing is taking standard drugs, in the case of MS, just 2 standard immune drugs that have been around forever. They don't even have patents on them anymore. And we mix them in a way to try to induce tolerance. And we do them at doses that have been used forever in the hematology field, that is for treatment of aplastic anemia. It's the exact same doses. So there really isn't an experimental treatment here. The concept of being able to reinduce tolerance by doing that is a little experimental, but it appears to work. And it's, you have to tweak it to make it work well, but it appears to do that. So the other is it's expensive. Okay, fine. A stem cell transplant of our institution with a non-myeloablative regimen is about $125,000 for MS. But the point is, and the point that's being missed, it is cost effective, it appears to be, because you're using standard drugs that no longer have patent protection, so they're cheaper, and it's a one-time treatment, and you're off everything afterwards. And if you look at the cost of all these drugs, whether they're Copaxone or Tysabri, the price is really amazingly high. So if you're willing to annualize the cost over about 15 to 18 months, you should start saving money, whether it's for private insurance or for government health. It should be cost effective. One of the things we want to do is actually a cost effective analysis. It gets complicated, but it makes sense it should be if you just look at the cost of the drugs and look at our treatment. But of course, the regimen you use determines the cost. You use these myeloablative regimens, they're much more expensive and toxic. We don't do that. We use non-myeloablative. Okay, the other thing is patients on drugs, it's very expensive. Well, insurance is paying for it, but if they lose work and they lose their insurance, they lose coverage because they don't have that kind of money. We have people on Tysabri insurance paying $6,000 a month. They can't afford it. Even Copaxone and interferons are $65,000 a year. They can't afford it. They go off treatment. They get worse. And a lot of that deterioration they can't recover from. Whereas a one-time treatment, if they lose their job or they lose their insurance company and they don't need treatment, it's a win-win. Okay, here's a wrong assumption, treat it like cancer. And that's probably because this field came out of hematologists that use transplant leukemia. That's how I was originally trained. I gave all that up. I haven't transplanted leukemia or cancer in about 15 years because I focused on this new area. And you have to approach it differently. You want to use non-cancer, non-myeloablative, immune-specific drugs. They're a lot safer, and your goal here is different than in cancer. Your goal is to reset the immune system, so you just want to focus on that and avoid myeloablation or avoid any toxicity to any other organ system. It makes it safer, and it kind of makes sense. That's why you're doing it. But still, there are people that are focused on this cancer regimen approach. Wrong is more intense the regimen, the better. And I just showed you the 3 studies. I don't have time to go through it. I wish I did in scleroderma. That's actually the most expensive and the most intense regimen appeared to be the least effective. So that's not necessarily true. It's really a balance. And whenever you deal with immune modulation or immune suppression, you know that. You deal with drugs for immune modulation. It's a balance that you have to achieve when you're treating these patients between risk and benefit. And more is not necessarily better. And I'm saying that because I fought that in this field. When I first started this field, people looked at me like, whoa, what planet are you from? And now I see people in the fields, whether it's neurology or rheumatology, wanting to do even more intense myeloablative cancer regimens. And I'm the one saying, no, that's a bridge too far. It's very interesting how things change with time. So there's a lot of misconceptions, and that brings up a very important point before I get the data, and that is how do you acquire knowledge? And I think that's underappreciated and undertaught. And there's something that I've recognized that goes on, and that is the entropy of decreasing knowledge acquisition. Okay? Entropy really is not just a loss of order, it's a loss of knowledge. And the universe is always spinning in that direction, and you have to fight to re-get that knowledge or order. But the basic place you find it, the truest place, is doing the original research yourself. And you know that when you do it. That's where you find out what's really going on. After that, you read, if you didn't do it, you read the original article. But you all know when you write an article, information is lost. I mean, you have to condense it in 3,000 words. You put as much in as you can. But there are certain things, information that is lost. And that's already lost for someone who hasn't done the research. But at least they read the original article. But if they haven't done the research, there's a lot of things you won't understand in that original article. When you do the research, you pick it out easily and you see what's true or not, and that the data is always correct, but the interpretation of the data by the authors isn't necessarily correct. And by doing the research, you know that. The third level of where you're now losing more and more knowledge of what's really going on is you're reading a review by some specialists in the field. Well, at least they're specialists. I've been asked to do so many reviews, I say, no, I don't have time. I want to get the primary data out. That's where the truth is. Most recently, I finally capitulated to a prestigious journal to do a review, but generally I always say no. The other is a review by non-specialists in the field, which I see all the time. And what I actually see is the doctors who write most of the reviews actually don't do the work because they have the time to do the reviews. And there's a lot of stuff lost in that. I know. I developed this field from the beginning, and I can see how it's lost. And finally, of course, you go to newspapers or television, you know, it's being done for basically a sixth grade audience. And the details aren't there. It can't be there because you need a 5-second soundbite. And below that is social media bloggers that are totally outside the field. The more the emotional content, the more unfounded what they're saying, the more people go to their blogs. And unfortunately, I'm finding younger and younger doctors getting information out of social media, of all things. I always tell the young doctors, look, go to the original source. Before I go to my clinic and I have MS patients, I look at every MRI, not just the one we did right before clinic, but we have them downloaded from years before if they're down on the outside to compare to see what's going on, to see if there is accumulation of new disease or not. It tells me a lot. And I sit with the neuroradiologist. A lot of information is gained by going to the original source. Don't read the report. A lot is lost in the report. Go to the original source. It's same with tissue biopsies. Any organ that's biopsied, I look under the microscope with a pathologist myself because it's lost just in the report. But what I find young doctors is because there's so much information to learn, they're going to social media, and it's really inaccurate. And how I want to show you that is here. And this was a really good paper on social science in Science recently, Science March 8th, 2018. And it's about social media and science, and it's the spread of true and false news online. And what they found is if you had a bot or a computer or artificial intelligence spreading the news, the amount of false and true news was equal. If you had humans doing it, there was a marked increase in the spread of false news. Humans spread false news online. Why would they do that? Why do people gossip? There's something about saying this terrible thing I know you don't know that somehow gives you some credentials. And if you're doing it online, you can get people hitting your online site, and there's something addicting in young people hitting these sites all the time. I see them in the elevator, I see them at dinner, someone across, they're hitting these sites. But it's inaccurate information, and you need to know that. And I'm kind of concerned where we're going as a society and as professionals when that is starting to corrupt where you get your knowledge. All right, so let's go back to MS and transplant. The concept I had goes back to my first paper in 1995. I actually had the concept before that when I was a fellow at Johns Hopkins. I can tell you how it came about, but we don't have time. In any event, I wrote up an editorial. What happened is I was presenting some animal data at the EBMT meeting in Manchester, England, and the editor of bone marrow transplant came by and he saw that. He said, this is very interesting. If I had MS, I'd want a transplant. Will you write an editorial? You know, I was a young fellow. I said, yes, absolutely. I was so glad to do it. And then we spent years in preclinical animal models before going to attempting to write any human trial. And these are just some of the publications in just MS. Of course, we did other diseases and other publications about MS or animal models of MS, but these were kind of important. It worked in EAE, an autoimmune type of MS, but only in the relapsing remitting phase, not in the progressive phase. It didn't work. I knew that from the animal models. Back then, nobody quite understood that, but it was very clear now the progressive phase is axonal degenerative phase. It's not an immune-mediated phase of the disease. And when we did it in TMEV, it didn't work. In fact, animals died from release of the virus within the central nervous system. And so actually, if I'd started with the TME animal model, I probably would have stopped. But fortunately, I didn't. And fortunately, no patients have ever behaved like they had an active viral infection, because they did, they'd probably die from the procedure. But I'm always worried that, you know, you have a fulminant type of MS that you better make sure it's not a viral encephalopathy, because this would be exactly the wrong approach from the animal models. And actually, the animal models did hold up to what happened in humans. But notice, and then we started doing our clinical work, we were really confined to the hematology field, which is the field I was originally trained in. Nobody else was very interested in what we were doing. And I reported on a clinical trial in 2003 when we had to start in secondary progressive MS. Remember, our animal models said it wouldn't work there, but my NIH advisory panel made us start there because nobody had ever done it. Well, it didn't work. And in the publication, in the title, I put failure. Because I wanted everybody to know, don't do this in progressive MS. It didn't work, and actually our animal model predicted that. So it doesn't work in progressive MS. And what was going on back then is neurologists would say, well, I want to try everything else. This is too dangerous an idea, and we'll reserve it for end-stage secondary progressive MS. But of course, then nothing works. So, and transplanters kind of don't know the difference. They don't know MS. I did, but again, for the first time when you start a trial, I guess it is an appropriate place to start, as the advisory panel mandated, because nobody had ever done it. But there was no weird viral infection or anything like that. And then we went on. What I want to show you, finally, we got into the neurology literature, Lancet Neurology in 2009. But we were using Cytoxan and Campath, and it was very effective. You know, the EDS improved by more than 1 point, and everybody was very durable, and, you know, that was very exciting. But we did bring out that we were seeing secondary autoimmune disorders, especially ITP as well as others, that were way too high a rate. And so, for some reason, that didn't get much attention at that time, but we stopped using Campath because of that. And it's true, and now if you look at the data on the immune analysis of people treated with Lemtrada, there is, in the clinical side, a lot of secondary autoimmune disorders, not just IDP. But on the immune analysis data, what happens is it's a very highly effective immune-ablative drug, Lemtrada, except memory B cells sneak through, and then they're not regulated by T cells, so you get all these secondary autoimmune disorders. So we definitely don't use it. Remember, the toxicity and efficacy has nothing to do with the stem cells. It has to do with the drugs in the regimen you use. So then we switched, and we reported in JAMA 2015 all our data and everybody we've done on and off study with a non-myeloid approach, the initial Cytoxan Campath, and then Cytoxan ATG. We got rid of the Campath because of the secondary autoimmune disorders. And we had 151 patients. That was reported in JAMA 2015, open label, non-randomized. No treatment-related mortality. One patient did die late from hypertension that had not been well controlled and had not been compliant with drugs, but not any treatment-related type of mortality. And this was the regimen we used. It's very simple, cyclophosphamide. And cyclophosphamide has been used in MS before we ever considered doing it. Dr., I think it was Weiner in Harvard, published New England Journal with Cytoxan, looked promising, and then Vancouver did a study, but they really did it in secondary progressive, and it didn't work. Well, nothing works in secondary progressive. So, but, you know, it had been used. We just use a short, higher dose, the same dose used in aplastic anemia, which is really an autoimmune disease. It just happened to fall in the field of hematologists who would transplant it. And ATG, the same real doses used in aplastic anemia. They're always important. The details in what you do are so important. That's why you have to do the research yourself. And I don't have time to go into those details. But for instance, ATG, we start at 0.5, and then we go up on the dose. The reason we do is that decreases the fever from the drug if the initial dose is much lower, because ATG can give a high fever. And unmanipulated peripheral blood is infused on day 0 as an autologous supportive blood product to hasten recovery of cytopenia to get out of the hospital sooner. So here were the details from that 150 patients. A few, even though we knew not to do secondary progressive, we did a few in transition, about 20, and there was really no change in EDSS. It didn't help, it didn't hurt. Did we stabilize? I don't know, but I think I call that a failure. All the rest were relapsing remitting, and you see a marked improvement of greater than 1 point in EDSS that had never been seen in any study before. And if we separated it out by age, and I actually, this is in the supplement, that publication, not in the actual publication. And I was even afraid to put it in the supplement because if you look, we did a few people aged 46 to 58, and they improved, not as much as younger people, 18 to 25. So you can improve independent of your age, but the caveat is you have to be relapsing remitting, and the problem is most people that are 46 to 58 do not have relapsing remitting disease. you know, what is it, 85% are relapsing remitting at onset, but by the time of 40, only about 40% are relapsing remitting. And so, you know, that's the caveat. If you don't know what you're doing, you're going to be transplanting secondary progressive, and it's not going to help. But if you truly do have relapsing remitting at an older age, you can still help them. And this was a very important detail in that if we had a sustained fever over 3 consecutive readings in one day greater than this, here's the fevers, you know, 38.5, 39, greater than 38 or less, you can see these sustained fevers. Initially, the EDS improved over 1 year, and then it got worse. And it got worse without the MRI showing new lesions. And I think that's axonal damage caused by the fever with late axonal degeneration. And so it's very, very important to block that fever. And that fever, all our patients were culture negative. That fever is from ATG. And so that's an important point that you won't see in treating cancer. And cancer doctors won't know this because they get fever. They're not going to give steroids for going through a transplant for cancer or leukemia. They're worried about infection. They're going to pan CT everything, pan MRI everything, pan culture everything. But you're not going to find anything, and the patient's going to sit there and cook, and then they're going to do worse later. So what we do, if we get an ATG fever, we use preemptive antibiotics. We just throw them on board to cover. We always draw cultures. They always end up negative, almost always. And we broaden coverage, usually cefepime and vanc, you know, and then we add Solumedrol, 250, the next day 125, 125. And the interesting thing is, you know, an MS patient, when they get fever, they have a pseudoflare, and they're laying there and can't move, and they look terrible. You give them the steroids, and 60 minutes later, they're up, walking, smiling, talking, totally normal. It's not septic. It's late ATG fever. And it's important to know that and block it, but always, always carefully look for infection, chest x-ray, urine culture, Legionella, antigen in the urine, and you know, blood culture, so forth, expand antibiotic coverage, but it ends up being ATG. And this is what I wanted to show you is these non-randomized open-label trials. What was NADA? No evidence of disease activity, which you all know means no clinical relapse, no progression, no new lesions on MRI. And here's 3 studies. The HALT trial out of Seattle and Duke, which I think had 25 patients, reported in JAMA Neurology. Here's the Swedish trial of Uppsala, Sweden, which had 41 patients. And here's our trial of 151 in JAMA. They were all reported around the same time, and if you look at NADA, they're very similar. So the HALT uses the more toxic myeloablative beam regimen. We use Cytoxan ATG. The Swedish started with HALT, and they switched the regimen to the Cytoxan ATG like we do. They saw no difference between the two, and everybody kind of comes out the same, no evidence of disease activity, which is interesting. But the other, you know, we're not connected to each other. We weren't comparing notes. In fact, there's a little bit of competitiveness between the centers, but the results seem very similar in terms of NADA, which is probably the best way to look at outcome in this disease, not relapses anymore or progression. But in any event, how does that compare with drugs? And here's the data on drugs. So here's natalizumab, ocrelizumab, cladribine, lemtrada. A lot of drugs are 1 year, some 2 years, not too many further beyond that time point, whereas just by training in transplant, we always follow for 5 years. That's why we follow them out longer. It's just, it's innate in our blood to do that. But most drug company trials, you kind of get a 1 or 2 year, and then maybe sometime later you get longer follow-up. This is the data from Harvard, the CLIMB cohort data of everybody, no matter what they were treated, and what NADA is on their patients. And you can see by 5 years, it's about 18%. If you look out here, it's around 70% in the transplant arm. So that's a big difference. Now, this was whatever they felt was best to treat the patient with at that time. So there seems in the non-randomized studies to be a big difference, but that made it possible for us to calculate how many we should do statistically to see if we can find a difference. And we ran a trial, a randomized trial that was done at Northwestern, at the University of Uppsala in the UK, Sheffield in Sweden, and I mean University of Uppsala here, the University of Sheffield in the UK, and in UPSI, University of São Paulo in Brazil. And we called it the MIST trial for multiple sclerosis international stem cell transplant trial. And so I'm going to show you the results of everybody. The last patient was enrolled in 2016. Everybody's more than 1 year, and I think the mean or median is 3 years or 2.8 years at the time we wrote this study. Importantly, the evaluating neurologist was blinded. You cannot blind the patient. They know if they're in-house for 3 weeks or they're not. You can't blind me, but you can blind the evaluating neurologist, and we did that at each center. So here's our trial profile. We had 916 inquiries. A lot of them failed just by a phone screening questionnaire. That failure is usually they were secondary progressive, or they were relapsing remitting but not active enough. 182 came for evaluation and failed, and 110 were enrolled. So only, about 10% of patients ended up being eligible. And I think that's important. I think this is really effective therapy, as I'll show. But like any effective therapy, you have to respect it. And I think its role will be about 15% of patients with MS, maybe at most 20%, but certainly not more. And that's exactly how kind of came out in this trial. They had to have failed at least frontline therapy, interferon or Copaxone. They often failed other drugs, and they had to have had at least 2 confirmed acute attacks in the last year despite those drugs. So 55 got randomized to continued drug-modifying therapy, in which they switched the disease-modifying drug to something else. It was left up to the treating neurologist to decide what they wanted to do, although if we were asked, we did recommend Tysabri. About half got Tysabri, half got other drugs. They were allowed to change the drug after they started it. If there was a toxicity or it wasn't working on whatever, they could change it. And then 55 got the transplant. 52 were valuable. One was not treated, enrolled but not treated because it had recurrent infections and just didn't go forward. And 2 were found to have secondary progressive MS and were removed from the study. And that was early on with a center not making the differentiation between the 2. And then on this arm, on the control arm, 4 actually left to get transplants somewhere else. So we couldn't follow them. They were gone. They weren't going to wait. And in fact, if we look at the 2 arms, the ones that got randomized to transplant on this column, the ones to continued drug therapy on this column, you can see there was no real significant p-values in terms of sex or ethnicity, in terms of age. It was very similar. Duration of disease was actually slightly longer in the drug arm. But we did subset analysis on that. We're looking at duration of disease and outcome, and we didn't really see a difference. It didn't hit a significance. It was 0.007, but it was close. Everything else was not significantly different, including the number of prior immune modulating suppressive drugs they had, which are listed here. There was no big difference between 2 arms. And here's the number of different immune modulating drugs, 3.16 versus 3.15 in the 2 arms before they were randomized to whichever arm they went on. Baseline disability was no different, 3.3, 3.4, and the number of gadolinium-enhancing lesions was no different, as well as T2 lesion volume, which isn't on here. It got cut off the slide. It's in the paper. There was no difference. Now, for whatever reason, JAMA made us take these p-value column off. I don't know why. I think it's good to have it there, but it's not in the paper. They insisted it come off. So, but there were no significant differences between the 2 groups. And here's kind of the outline. 110 patients, 2 relapses in the prior year, despite standard therapy, at least frontline therapy, but it could have been others, and randomized to either the transplant over here, 4 doses of Cytoxan with ATG, and peripheral blood stem cell infusion, or to the DMARDs. And here's what they got, the different drugs they'd gotten. It adds up to more than 55 because some people got more than 1 drug or were switched. And we did allow non-FDA approved drugs that physicians give all the time. Again, we do that. That's why you have a license to be a physician if you feel it'll help the patient. Cyclophosphate's never been FDA approved for a patient with MS, but people use it, and certainly they did in some of our patients. Rituximab has never been approved, and people used it. Actually, Ocrevus is approved. Why didn't they approve rituximab? I think it's because it's lost its patent. So you get a patent on Ocrevus, you can charge $45,000 an infusion. If you do Rituxan, it's 1/3 that price. But actually, it probably works just as well. Okay, and you have the right to give it. But there's no FDA approval. But that's what being a physician is. So we allowed it because if you had bad MS, we wanted you to treat it as you would normally. IVIG people give for bad MS, not FDA approved. Plasmapheresis, they do, not FDA approved. But it's standard. You do these things. You need to do it. If you don't, just as well shut your hospital down. Acthar or corticosteroids. And then, of course, 4 left, you know, and went somewhere else. And that's even despite the fact that upon failing, they had to be on a drug-modifying therapy for at least a year. But after that, if they failed, they could cross over to transplant. Failure defined as an increase of EDSS of 1 point, sustained for at least 6 months by the blinded neurologist. Well, there was a person, despite promising to stay with whatever arm, didn't like continuing DMARDs, went to transplant. Others, you know, they were having new attacks. They were having new lesions in MRI, but blinded neurologists, EDSS wasn't up. They were very frustrated, and they just left and went somewhere else. So even with a crossover, we were losing some patients. Now, what about toxicity of the transplant, which is, of course, very important, should be number 1 and first in everybody's mind. There were no deaths, no grade 4 toxicity. There were grade 3. They were mostly neutropenic fever and electrolyte, and they're in the supplement of the article. There was 1 bacteremia during neutropenia, but we thought it was really a skin contaminant because it was staph epi, and it was just 1 of 3 cultures positive. There was, at our site, 1 positive culture. There was also 1 bacteremia, and that was in the UK, but asymptomatic. There were no early or late opportunistic infections, no CMV, no PCP, no PML, no Epstein-Barr virus. And if we look now from the blinded neurologist, the EDSS, by the evaluating neurologist, they all started the same place, the 2 arms. Again, 3.3, 3.4 on mean. The ones who stayed on DMARDs over 1 year, now this was highly active MS, deteriorated. Their EDSS increased. So in other words, the neurologic function got worse. I know you guys know this, but in case somebody here isn't a neurologist. Whereas in the transplant arm, it actually got better. Their neurologic disability improved over that first year. Now, the reason I can't show you data beyond this first year is because we started allowing crossover after that if that EDS increased 1 point and was sustained for 6 months. So the bad actors would fall over to transplant, and so that would change this arm. So that's one of the limitations of our study. We couldn't really compare the 2 arms after 1 year, but at least it allowed the study to continue because people who were doing bad did cross over to transplant, and they stayed with us. If we looked at NRS, which, as you know, goes the other way, you know, that, you know, here's the DMARD arm, and the NRS got lower, so they did worse, whereas the NRS improved, the number got higher, which is improvement in the transplant arm over the first year. And that was pretty much true in everything we looked at, and it's in one of the tables in the JAMA publication with p-values, which were cut at 0.001, because that's what JAMA won't allow you to write a lower p-value, but some of these p-values were much lower than that. In any event, if we looked at the percent change in MRI T2 lesion volume from baseline, and so normalize everybody's baseline at 100%, you can see on continued drug therapy, the T2 lesion volume increased to about 134%. On the transplant arm, it decreased to about 66%. There was a marked difference on that. And I was very grateful for Dr. Nelson's help on this. And in fact, we sent her MRIs blinded to look at as well as she came up to double check these readings at our own center as an independent analysis to make sure we were doing it correct. And I think this hasn't been seen in other studies. So that's very exciting. I don't think it's the stem cells causing any neural repair or shrinkage of these T2 lesion volume. I think it's the brain repairing itself if you do it early enough before they have progressive disease when the repair function is lost. So in any event, if we look at relapse-free survival, you know, the ones on drugs, relapse-free survival was significantly different than on transplant after the procedure. If we looked at time to progression, again, by the blinded neurologist, they're significantly different between the 2 arms. Here's progression after transplant. Here's after DMARDs. Again, we couldn't do anything in the first year because nobody was technically allowed to progress in the first year because just the way we did it, so we could compare the 2 arms. If we looked at NADA, no evidence of disease activity, NADA 3, so no acute attacks, no new lesions on MRI. What we see here, and no progression, is this is the transplant group, NADA, and this is the DMARD group. And there's a big separation between these two groups. And I think that's even worse than you would expect, but I think it's worse because we selected highly active MS, where this therapy is most likely to show its promise. So again, 55 in each arm. As they failed at the time I did this slide, 31 had failed and crossed over to transplant. So if we look at all transplants, the 52 initially transplanted and 31 failed. For 5 years, how are they doing? You know, some people haven't hit 3 or 4 years or whatever. Everyone's beyond 1 year at the time we did this. But if we look here at the EDSS, it improved and then it kind of stayed stable, which, again, I don't think you normally see those type of results. And again, these are people that crossed over. And so the interesting thing is even though they got worse and the EDSS was elevated for at least 1 point for 6 months, it improved after the transplant, which also means that that definition of progression is not irreversible. If you're in relapsing remitting disease, you have a really effective therapy. And that needs to be readdressed. Some people use 0.5, some 1, some 1.5 for progression over, and it's sustained for 6 months. We use the 1, but it means it's not irreversible. And if we look here at MRI T2 lesion volume in all the patients, including the ones that crossed over 5 years, you can see that there's this improvement, less so out here, but even 2 to 3 years, there's improvement in lesion volume. And I'm kind of amazed how smooth the curve ended up to be. So this was the study, and the lead investigators at each site here in America. Of course, I include Flavia here for the MRI analysis. At the UK, in Sweden, and in USP, or University of Sao Paulo. Now, there are potential limitations to our MISS study, and I think those are important for any study to understand, because if you go outside where we designed it, you may see different results. One of them is the crossover prevented long-term follow-up of the drug-modifying therapy, or disease-modifying therapy of the drugs. So we really don't have long-term follow-up on that arm. The small number of patients in our study, 110 compared to the usual drug company trials, is a limitation, but it's not as much a limitation as you think, because we predicted before we started that the transplant would be so much better that we could do it with a smaller number of patients. Now, it turned out that that kind of guess prediction was accurate. So, the reason most trials have like 150 or 200 patients in each arm or even more is that the difference between the two arms is very small, so you have to do a large number of patients to get significance. And that's equipoise, because you're not supposed to ethically do a study if there's not equipoise. If one therapy is much better than another, you shouldn't do it. It's not ethical. So all these big drug company trials are based on equipoise, that they're about the same, so you have to do a lot. So if you have one you think is much better, you can do a lot less, but then you don't have equipoise, and the way we got around that is we allowed crossover after at least 1 year by the blinded neurologist, EDSS increasing, sustained for 6 months. So it's not as bad as you think, the smaller number. It's actually kind of encouraging that we could see such a difference with a smaller number. We didn't allow ocrelizumab, and that's because the study completed enrollment in 2016. Ocrelizumab was not licensed till 2017, so you could say we didn't compare it to highly active ocrelizumab. Or Lemtrada. Lemtrada was licensed 2014, but we didn't allow it because of the crossover arm, because the autoimmune disorders that arise after Lemtrada and the persistent CD4 lymphopenia, I was worried if we did a transplant, we're either going to get a bad autoimmune disease, secondary autoimmune disease, or on the crossover, or we get an infection, and everybody would blame transplant, although it would be the combination of the Lemtrada followed by the transplant, so we just didn't allow it. The EDS NRS was done by a blinded neurologist, but relapses by an unblinded investigator. And then importantly, our results are for highly active MS, failing at least one first-line drug with moderate disability, okay, 2 to 6. You can do higher disability if it's really inflammatory, and we've done that. We had a patient sent overseas to another center here in America. She walked in the door within 2 months, was basically bedbound. They did plasmapheresis, IVIG, many things. Then they called us, sent her to us, and the patient was in a coma. And I thought, oh my gosh, this is way too late. I even did a sternal rub, no response. But there was still plenty of enhancement in the brain, and we did a transplant. She's about 3 years out, back home in another country, walking, walks with a limp, but walking. So you can do that, that malignant MS, but that's very rare. And I think you could do it at an earlier EDSS. There's these rare young people come in, you know, and they look pretty good, but their MRI already has a pretty moderate to heavy burden of disease, and you're like, why aren't you having more disability? And they haven't been treated yet. And I think those you could probably do up front. Those are the type of people you start natalizumab or Ocrevus on up front. And I think those could be candidates. But nevertheless, I think this is a therapy limited to about 15% of the population of MS. And that's because anything really powerful you also have to respect. And I promise you, you can never, even with our non-myeloablative safer regimen and a lot of experience, you can't do this forever without eventually someone dying, some fluke happening. It won't be common, but you can't prevent it. So you have to be careful in this, and you have to be, you know, all our consents emphasize that, and they emphasize no benefit, even though now we see this. And patients talk to themselves, and we have the paper out. For any patient, we always emphasize there may be no benefit and there's risk of mortality. So they have to know that. So where do we go with this? Well, first, you know, I wanted to publish the results, which we just did. We want to do a cost analysis. But it's nothing I'm going to do. I need someone who's used to doing that. And we finally got university approval for a person. We found them for their assistant professor slot. They wanted associate. They should get it. We went back. Going through the committee, it took months, got it approved. The person got another job. So if you know, yeah, if you know anybody that would be interested in doing this, I think this is really important. Cost analysis. There's only so much money to go around. So that's very effective. And so now what we want to do is improve what we've already done with a non-myeloablative regimen. That is, we want to make it safer. We're calling that MOST, maximizing outcome stem cell transplant. So our goal should be to make non-myeloablative transplant even safer. And that's what we're trying to do. Now, I know other people are going to do other stem cell transplant trials, just like they did in scleroderma. You know, we did the first back in Lancet, and then the Europeans in JAMA, and then the Americans, other centers in New England Journal. But what I've noticed is going on, and it's going on in America, gang, it's the more intense regimen, BEAM, that's a cancer regimen, and intense mobilization of 4 grams of cytoxin. And, you know, I wish nobody bad. I want them to succeed. I absolutely do. But I feel it's a bridge too far, and it's academic, because if you can get really good results without doing that, and a lot cheaper, 125 versus 200,000 to the insurance company or patient, it's kind of a no-brainer which way you're going to go. So the goal isn't necessarily a more intense regimen. It's going to happen, and my worry is if they have a death or toxicity or whatever, you know, neurologists will say, oh, it's transplant. No, it's the regimen you're using. Okay. Diclizumab. Just because that went off market doesn't mean you stop all MS drugs. It was diclizumab, okay? But there's this concept, all transplants are the same, and that's just not true. Now again, this publication, Dr. Chirac gave this to me, this slide. I thought it was really cute because it was going back and forth 9 months to get that paper with. It's very interesting in the peer review process to see how the reviewers are thinking. It's almost like it should be published, their questions and our responses, because we're in different worlds, and part of it is educating each other, and it can be frustrating, but it's an important education process, I think, both for the reviewer and for me, to see what they're thinking and why we're missing each other. But anyway, we finally got through the Grim Reaper here and got the paper accepted. This is what I wanted to show. This is a cost analysis by, not by us, by other neurologists in neurology, 2015, but it was a 2013 cost analysis, so we're 5 years later. They've got to be more expensive. And here was the annual or 1-year cost of all these drugs. I mean, that's surprisingly expensive, okay? And that doesn't include physician costs or IV infusion if you're dealing with like Tysabri, or toxicity monitoring or blood work, or, you know, EKGs for Gilenya or whatever. And they estimated to stop one relapse is $80,000 US. And not listed here is Lemtrada, which is much, much more expensive, and Ocrevus, which is much more expensive. So that's what I'm saying. If you do non-myeloablative at 125, this should be a cost savings. given the durability of this response, which at 5 years in our randomized trial, only 16% had relapsed by 5 years. Given the durability of that response, this should be a cost savings to society. And the truth is, it's grandiose to say everybody should get everything, but there's only so many resources to go around. So you want to make it as effective, but it also as cost effective as possible. And that's why I'm saying I think this approach with the myeloablative beam is considerably more expensive, and insurance is going to have to pay again. So I'm not sure at the end of the day, I mean, a lot of good data will come from it, but at the end of the day, it may not be, you know, where we end up treating patients. And then I just finally want to show you this. We also treat neuromyelitis optica, and we just submitted that paper, so I'm not going to show you the data, but I'll tell you briefly. It was, you know, 12 patients, aquaporin 4 positive neuromyelitis optica, the classic long central canal lesions. 100% of them had them in thoracic, about 2/3 in the cervical, and the classic optic neuritis where there's atrophy involvement of the chiasma where the optic nerves cross. You know, it's a very different MRI with little brain involvement. But anyway, they were all aquaporin 4 positive. It turns out 10 of the 12 became aquaporin 4 negative after the procedure, and they've all stayed in remission out to 5 years. So this is a 5-year paper. Everybody's 5-year but one, that's 3 years. 2 at 6 months stayed positive, and at 1 year were positive. They were on no treatment, and 1 relapsed at 18 months, 1 at 2 years. But the other 10 that became negative, they never relapsed. Of those, the majority stayed negative. 1 became positive at 3 years and then was negative at 4 and 5 again, and another 2 became positive but low, and they never relapsed. And so what we did here is we, of course, send the person who first told me I should apply this treatment to neuromyelitis optica was Sean Pittock at Mayo Clinic. When I gave a talk about transplant for MS, we met and shared a cab ride back, and he said, you should do this. And so I did. So I called him, I said, these are our results, and he said, yeah, we store the serum because we send them there for the aquaporin 4. And initially they did it by immunofluorescence, then cell binding assay, and now they're most sensitive fax. So they could go back and do a fax on everybody, and they could go back and do cell killing to see if it stopped activation of complement. And in fact, it stopped cell killing. You know, it's in one patient where the antibody persisted with no, or returned with no relapse, there was no cell killing, which was very interesting. So, and I'm not used to that data, but as he said, they've never seen data like that. So we've submitted that, we're hopeful. But here's an example. Our transplant's $125,000 versus eculizumab, which blocks complement. Eculizumab is $500,000 a year every year. And that randomized trial I've heard has just been completed. I mean, you have to, in any event, I think there'll be more work on stem cell transplant neuromyelitis optica. And again, you know, this was confined to aquaporin 4 neuromyelitis optica. So here's the summary. Unlike drugs, non-myeloablative. I want to emphasize that because I've always done that. I've always emphasized that against the cancer myeloablative regimens, which are more intense. Maybe more effective, I don't know. Actually, in the case of systemic sclerosis, it wasn't. It was less effective, more costly, less effective. But non-myeloablative HSCT is a one-time treatment, unlike continued drug therapy, that can be done safely in, it's very important, experienced centers with the right regimen. And I'm not even saying we have the optimal regimen. We have a good one, but it can be optimized. In relapsing or remitting MS, not progressive, but in relapsing or remitting MS with frequent relapses, non-myeloablative HSCT reverses neurologic disability. The EDS decreases by more than 1 point. It's sustained. We improve quality of life. And the interesting thing is, on our randomized trial, that quality of life SF36 did not improve on the drugs. But when I read the literature on these drug trials, whether it's in Lancet or New England Journal or Lancet Neurology or whatever, they don't even report quality of life, which always struck me as odd. And I dug and dug and dug, and I found there was a paper in a small journal on Tysabri quality of life where they combined all the trials together, so they had like 5,000 patients, and at 2 years there was a 2-point difference in quality of life between the Tysabri and the control group, which was an interferon or Copaxone or whatever. But that was statistically significant, but you know what? It's clinically meaningless because you have to have a 5-point difference for an improvement of quality of life. So that's just of no relevance. It doesn't improve quality of life. If you look at the difference, we had like over a 20-point difference in quality of life. So it improves quality of life, which these drugs aren't doing. Well, think about it. If you get better and you get off drugs and all the potential side effects of drugs and discomfort in your life dealing with it, your quality of life improves. It decreases MRI lesion burden. We showed that it went down about 33%. It has a durable 5-year remission with a prolonged NADA, no evidence of disease activity. It appears, we haven't done the analysis has to be done. It appears to be cost effective, and it appears to be changing the natural history of disease, for which we have no drug company or pharmaceutical involvement or support, and the investigators get no financial benefit, patent, license, no lecture honorariums. I hope I'm not getting an honorarium. I always tell my secretary, I don't want honorariums. You know, that's not why we're doing this. Because there is no product to license or manufacture. And I think that's where things are confused out there. This is us in Chicago because the medical school is right downtown. Thank you. So those are all good questions, and I agree with you, everything you said. However, at the end, the last point, treat with Cytoxan alone, no. Johns Hopkins did that with the same dose of Cytoxan, 200 milligrams per kilogram, divided over 4 days, 50 milligrams per kilogram. And initially looked good, and they had a very high relapse rate, and they stopped doing it. And unfortunately, I don't see it as ever published. It was just kind of shut down. And that's very important. You need to publish results that aren't encouraging either, just like we did with failure in the title Back in Blood when we did secondary progressive. So no, there is a threshold you have to be at to eliminate effector cells and stop inflammation. I think, you know, there are ways to fine-tune what we're doing to improve it, but I definitely, you know, and I agree with your comments that I think Lemtrada probably does change natural history of this disease, but there's significant toxicity with it. I think mitoxantrone probably does, but significant toxicity in terms of late myelodysplastic syndrome and cardiac dysfunction, and so, you know, nobody really wants to use it. So I think the results you're seeing with transplant are much superior to what you've so far looked at with the drugs we just talked about. The goal is to make it as safe as possible. That's what really has to be done. And that's why I, you know, don't do those myeloablative regimens, which is, of course, now a big multi-center trial that's opened. Yeah. That's my speculation as to why after a year they did worse. So there's this acute effect, pseudoflare, and as soon as the temperature comes down, that resolves. But there's also what we saw late after 1 year, those that had that persistent fever, I mean, 104, 105, they ended up doing worse without new lesions on MRI. So that's why I make the assumption that, it's just like acute relapsing MS goes on for a long time before you get progressive disease. So I could see, oxidative stress and so forth from fever not showing the progressive effect until later. Yeah, thank you. Yeah, we do CIDP. Yeah, yeah, we've done CIDP. I need to write up the data and get it out. It's exciting data. So, well, it's the largest study ever done. If you go back and look at, what is it, ICE in those, we actually did more patients. I think it's 66 got a transplant. But the key with CIDP, this is, like the key with scleroderma is, it's in the heart, and I can explain why that is some other time. The key with MS is no inflammation, no response. So you want to use this in really inflammatory MS. The key for CIDP is, and if I ever wrote an editorial on it, I'd say that is it CIDP? Because of 2/3 of patients sent to us actually don't have CIDP, and they're sent by very good centers or private practice neurologists or whatever. And for me, it's very fascinating to find out what they actually do have, or at the end of the day, we, aren't quite sure, but it's not CIDP. And so we use the European Federation Neurologic Society, Peripheral Nerve Society criteria for definitive CIDP, which in itself isn't perfect. There are poems that meet that criteria, and they're really poems, and you don't want to transplant them because it comes rip-roaring back. You got to treat that like a myeloma. But there's a lot of other diseases, including body myositis, even ALS, and a lot of things that have come to us under the diagnosis CIDP, and they're not. And I think that's because it's one of the few peripheral neuropathies you can treat. And so, the patients want something, you give them IVIG, and I think there's some sort of placebo effect, or maybe it's pooled plasma from a lot of people. Maybe there's something in there, I don't know, that the patients kind of like it, but it's really not